So hello, my name is Andreas. Welcome to MRSA and infection control. This is a little bit of a funny session within hardcore staff meeting, but we have great speakers and we want to start right away, which we have to make up a little bit of time where possible. So I will not introduce the speakers. All of us had been here before, and we just start right away with Susan.
Great pleasure to be here to talk to you today about MRSA in hospitals. I was asked to talk about what is really needed. So there are a number of strategies that are used by infection prevention programs that are listed here. And I am going to see if we can rank them by effectiveness. I will say as a caveat, we all believe that they're all, you got to do multimodal things. So this was just an exercise, but it can be helpful for how you spend your time doing campaigns. Most staff and infection prevention programs can't really handle doing more than one major campaign at a time. There are things that I will not talk about. I won't talk about the data on hand hygiene. I think all of us in the field, if we could pick the one thing that you could only do, it would be hand hygiene. And so that one's ranked number 1 in its fixed position. And I'm going to put antibiotic stewardship at the end, and that's mainly because the studies that are done don't focus on MRSA prevention as an outcome. So we don't have those types of studies, but of course antibiotic stewardship is important for preventing the selection and emergence of MRSA in patients. So I will start by talking about active surveillance and contact precautions, and I'm going to highlight a recent paper that was done in the United States. The vast majority of really solid data, large-scale, impressive data for contact precautions and active surveillance comes from our VA system. So this is a system of 123 hospitals, and basically they have invested pretty heavily since 2007 on being able to screen every single person that comes into their hospitals for MRSA using nasal swabs, and to ensure high-fidelity contact precautions are applied. And they do this by hiring an MRSA coordinator whose full-time job at every single hospital is to ensure that this particular campaign is done well. And for that reason, they have been able to show year on year, effectively for 15 years, a tremendous amount of reduction in MRSA colonization and infection in the United States. In 2020, they had to deal with COVID, and because of that, they had to divert an enormous amount of laboratory resources, as we all did, for COVID-19 testing. And they could not maintain their MRSA screening for that reason. As you know, we had staff shortages, we had plastic shortages, and ultimately, there were also PPE shortages, so personal protective equipment, gowns and gloves that we use for contact precautions. And so they basically gave up the ship, and they said, every one of their hospitals, do whatever you want, but there's one criteria, is you must respond every single month and tell us what you're doing. And so this is what happened. If you take a look at those that actually maintained the bundle, it started at 100%. You can see in 2020 it went immediately to 20%. 80% of them gave up some component of that bundle that they were doing. And even after COVID was declared over, you can see that they reached about a 60% return, but not back up to 100%. There were about 15% that really gave up everything, either did nothing or only did active surveillance, which is for surveillance purposes, doesn't do anything to actually prevent MRSA. And then in between there are those that stopped screening but maintained contact isolation for those who they knew had MRSA. So the CPC here is their designation in this paper of contact precautions for those colonized, CPI, contact precautions for those infected. And you can see that about 40% started out to do that right at the beginning of the pandemic, coming down to 30. And finally, there were some that did active surveillance just to know where they were, and then only did contact precautions for those that were infected. So it was all over the map. And I'm just going to show you kind of those areas that had sufficient months of data to give you decent kind of confidence intervals. And you can see that for those that did nothing, MRSA HAIs, these are real infections. So true infections from MRSA, 0.22 per 1,000 patient days. Contact precautions dropped that by 44%. And if you added screening in order to detect more carriers, dropped it down to 59%. So again, the VA system, again, some of the strongest data really in the world, and such high volume data to really be able to estimate the impact of this particular intervention. They also stratified by ICU versus non-ICU, and you can see that the dominant benefit is among high-risk patients in the ICU, but still a clear benefit in those outside of the ICU. So I will say that the controversy of contact precautions is interesting. In the United States, there is a fervent vitriol that goes back and forth on this particular intervention. There is clear evidence that it works. There's clear evidence that MRSA will transfer from the patient to healthcare workers. That's incontrovertible. It's been measured time and time again. It's been shown by genomics to be the actual strain that the patient has. However, we are absolutely unable to overcome the discontent. And in the United States, it's about a 50-50 split, and it's a very, very fervent pro-con. And so COVID provided an even stronger freedom to back away from this. And so actually, we're probably right about now at a 50-50 split. And even the VA system, which is the source of all of these great studies, has really backed off and said, you know, we're going to allow some variation, and they had not adopted any decolonization, so we're thinking about allowing people to move into that realm as well. The only thing that I would say about contact precautions is that it works. And so if you stop it, you have to replace it with something. So if you actually have a substantial amount of MRSA that you're trying to prevent, you can't just walk away and assume that it was really doing nothing at all. So I'm going to shove those two things in between. We don't yet know where they're going to slate, but screening and contact precautions with a stronger effect than contact precautions alone. So I'm going to talk a little bit about decolonization in the hospital. They usually fall into two big categories: targeted prevention, which means you screen and find the carriers and then you decolonize them, or universal prevention, which is you basically treat everybody in a high-risk setting. For the preoperative trials that have been done, really the strength of it has been in a whole slew of different surgeries, actually, to find these MRSA carriers and then decolonize them just in time for the incisional time so that you could actually prevent MRSA from falling into the incision and producing disease. So this is about a 51% reduction in nosocomial Staph aureus infection in the hospital stay that an operation occurs, or a 59% reduction in skin and soft tissue infection. And so these are the strongest data. These are randomized controlled trials that are heavily cited for this purpose. We performed the REDUCE MRSA trial. It was published in 2013. Again, it was a pragmatic cluster randomized trial, and that generally means we are not parachuting research staff in. We train, we bring research staff in to train, but we do not do the actual intervention. So all of the intervention is done by the usual care staff, and that's what makes it pragmatic. There were 3 arms in this trial. One was routine care, which was screen everybody in the nose in these ICUs and isolate them with contact precautions. And then, this is why I'm sharing this study, it's a head-to-head comparison between targeted decolonization, that is screen, isolate, and when you find the carriers, you decolonize them, versus don't screen and just decolonize all. And so we're talking about 5 days of mupirocin and daily chlorhexidine. This trial had 75,000 patients, and the way that this is done, because we only had 43 hospitals that were randomized, is that we actually did a difference in differences approach. That is, we compare every hospital's intervention period to its own baseline. That allows you to account for unmeasured confounders, and then we use fancy statistics to cluster to be able to look at the evaluation across the arms. And so that explanation will help you interpret this graphic. So this is the main outcome of that trial, MRSA clinical cultures in the hospital, in the ICU-associated setting, so day 4 and after in the ICU. And if you take a look here, actually day 3 and after in the ICU, if you look at the y-axis, you'll see a hazard ratio. That is the ratio of the intervention period to the control period. So for example, in arm 1. They're doing screen and isolate during the intervention period and screen and isolate in the baseline period. So you expect them, all these circles, to be right around 1, and that's what you see. Every circle is a hospital. Every size of the circle is the number of ICU patients that contribute to that data point. What you'd like to see in the intervention arms is that all the bubbles behave similarly and that all of them ideally would come down below that line. So you see the point estimate for targeted decolonization is a 25% reduction, and the universal reduction is better at 37%, significant reduction over control. So this particular data is helpful in determining that in the ICU setting, critical setting, universal decolonization seems to be better. This is a secondary outcome, MRSA bloodstream infection. We were not sufficiently powered for this outcome, but I show this slide for 2 reasons. One, in the universal arm, you see all the bubbles behaving the same way. So we would like to believe that if we actually had gone longer or larger, that we would have seen a significant drop in MRSA bloodstream infection. But I show this slide for the incredible disappointment of Arm 2, for all the effort to screen, to find them, and then to decolonize them. You see absolutely 0 movement in the point estimate for MRSA bacteremia. And this is a massive study. It is very unlikely to be replicated. This is also another benefit of this trial. This is a 3rd outcome that we looked at, and this is all pathogen bloodstream infection. And you can see arm on arm, there is a sufficient benefit to targeted decolonization over routine and universal decolonization over targeted. And so for this reason, I'm going to rank the universal decolonization arm in high-risk settings like the ICU higher than the targeted arm. This is outside of the ICU. I mentioned this briefly yesterday, but this is another trial that we did, 53 community hospitals, all in the non-ICU, 200 non-ICU units. They're randomized by hospital. And ultimately what we found is that in community hospitals, it is not beneficial to decolonize everybody because they stay only 3 to 4 days. They're fairly not ill. But in those with medical devices, we actually could reduce significantly both MRSA and VRE each by 37% and reduce bloodstream infection by 32%. In these community hospitals, those with devices were only 10% of the population. They were responsible for 60% of the bloodstream infection. So big, big value to target. In the academic medical centers or tertiary, quaternary community centers, the calculus changes. And if you see very, very complicated patients, the cost effectiveness analysis demonstrates that universal is better for those settings. So I'm now slating this in on the prevention of MRSA acquisition, that is the spread from one person to the next. Hand hygiene is at the top. Universal decolonization is second, and contact precautions after that. Not necessarily because the benefit is different. Contact precautions works incredibly well. Universal decolonization works really well as well, but there isn't the vitriol against it yet. So contact precautions is going to fall down just because of the intolerance that at least exists in the United States. It may be quite different in your own countries. But the other reason why decolonization is listed higher is because it does something for those who already have it. And we talked a lot about this yesterday. There's really nothing else. Hand hygiene, cleaning of the environment, contact barrier precautions, they're not doing anything for those who are already found to be MRSA positive. And in the United States, as you have heard, we have a lot. So it becomes important for us. Let's now do the last one, which is environmental cleaning. Okay, so here we go. MRSA, it is well known that the shed of MRSA positive carriers into the environment is equal. Whether or not you are colonized or whether or not you are infected, you shed profusely into the environment around you and into high-touch objects that we care about. We also know that discharge cleaning is not very good. So when we do terminal cleaning and the person leaves the room and you're about to go into what you think is a new clean room, that room is not often clean. So you can find a number of studies that have demonstrated this. In general, it's about 40% clean. You can get it to be better, usually about 85% clean with a lot of effort. And it's worse in long-term care. You all know that Staph aureus is incredibly hardy. It sits perfectly content on a number of inanimate surfaces, on a number of conditions for weeks, days, weeks, and sometimes even months. So we did this study where we were actually looking at Candida auris, but we were looking at other pathogens at the same time, and we were asking the question whether or not we could clean more often. Does it matter if we can clean more often? And so what we did is we cleaned the room because we knew that the cleaning, as I just showed you, was not particularly robust. And so we cleaned the room and we made everything go down to 0 on these high-touch objects, and we wanted to see how fast it reaccumulated. And you can see, and this is done in both hospital and nursing home residents, you can see it pops back up incredibly fast. It's exactly what we've always seen in other studies. The gram-positives are higher than the gram-negatives. Candida auris is pretty high as well. Staph aureus, you can see, is the fastest to come back. It comes back really fast at 4 hours. It stays high, and I'm sure it would have been there at 2 hours as well. So you can't clean constantly enough times to be able to deal with this rebound that actually happens. So we wanted to ask the question about whether or not all of these things that we do, and remember, I'm going to start out by saying that we deeply believe in multimodal needs because the behavior, the compliance by which humans do things is not perfect. So we do have to do things, and we have to try to make sure we don't have kind of loss of effect of ultimately protecting our patients. But it is of interest to understand whether or not, for example, if you clean or you decolonize, is it synergistic, is it overlapping, or is it additive? And these things can really matter in the way that we think about how we spend our time trying to drive in campaigns. So this is a small study. It's called the CLEAN study, Cleanliness to Eradicate Antibiotic Resistance in Nursing Homes, and it was done in only 2 nursing homes in California. And we did 4 phases. So we looked at 4 things. One was a decolonization phase, universal decolonization. Second phase was nothing, no universal decolonization, no enhanced cleaning. So regular cleaning, regular bathing was happening. Third phase was enhanced cleaning, where we really drove a strong campaign to teach them how to set up their carts and to really clean high-touch objects thoroughly. And the fourth one was the 2 combined. Each of these phases was 3 months with a 3-month phase-in. So there's plenty of time for washout in between. And during the 3 months of the intervention period, we sampled things 6 times. So every other week we did a substantial sweep. So this is the enhanced cleaning training. Again, we used microfiber cloths. We trained them on all the things that were high-touch objects and how well you do that. And we used invisible UV markers to feed back. So we could actually give them really visible feedback on whether or not they were or were not cleaning to a sufficient degree. These are the objects that we sampled. So as I mentioned, we sampled every other week during each phase for 6 sweeps. And this included 6 randomly selected residence rooms, 5 high-touch objects each, 4 common areas, which you see listed there, 12 high-touch objects each. And effectively, because we have 4 different phases, that ended up being about 1,000 object swabs for MDRO culture per nursing home. We also sampled the people. So we went through and we sampled 40 randomly selected occupied beds of nursing home residents for skin and nares, and that ended up being about 2,000 body swabs for MDR culture per nursing home. All right, so here's what we found. These are raw percent. So remember, objects are clustered in rooms and the same person is there. So this isn't the final answer because it's unclustered data, but this is the number of objects in these places that were positive in the control period. In these nursing homes, in the resident rooms and the common areas, you can see that 60 to 70% of objects grow in MDRO. So I know that's incredibly disheartening, and that just goes to show you what we're up against in our nursing homes in the United States. When you decolonize, you're not cleaning the environment at all, but you're actually stopping the plume of people shedding. And you can see that there's a dramatic reduction in the positive high-touch objects just by decolonizing. Enhanced cleaning is very, very similar to that, and you don't really see a clear synergistic reduction, at least in the resident rooms, when you put the 2 together. So let's now account for the fact that objects are clustered in rooms, right, with the same individual. So when you do the proper analysis where you do clustering on all of those things by person, by room, here's what you find, that decolonization reduces the odds of having a positive object culture by 80%, enhanced cleaning by 70%, and the two together do not add more than decolonization alone. What about the body? Now, we know that cleaning the environment is not supposed to change what's on the body, and so we don't expect it to do much. So, in the control period, you see 50% of patients are positive by the body sites that we were testing. In the past, I've mentioned to you that it's about 65%, but we did not do rectal swabs in this particular study. Decolonization drops that to 36%. Enhanced cleaning doesn't change the body site culture, and the two together are in between. So here you can see when you actually account for everything, again, decolonization much more effective in reducing body site culture, no surprise, than enhanced cleaning. So I'm going to plop the environment then actually at the bottom before antibiotic stewardship, because it in of itself, it works at the moment you apply it. I think that's not surprising. It just is the fact that we tend to clean once a day. We don't have the staffing to provide a constant cleaning mechanism. So that's the ranking that I would put, and I would say that this isn't used to say that we should do a singular thing. It's just to say where should we put our effort for large-scale campaigns to improve the quality of why we do the things that we do. So again, multimodal approaches are absolutely needed. Compliance and preference actually really, really matters as we're learning in the United States with contact precautions. And it's really, really important for us to think about the value of where we do the things that we do. So again, targeted decolonization having a pretty nice effect in the pre-surgical period, and that's where its strength is. So I will stop there, and thank you for the time.
Thank you so much. We decided we'll have common questions at the end if we still have a few minutes left in this session. So I right away asked Margaret to come up here, Margaret Ip from Hong Kong, who will be talking about decolonization too, and other ways to do it when the main things aren't around.
Thank you, Andreas. So I'm going to cut my talk really short, since we are a bit short of time, and what I'm telling you is really, probably what Susan detailed in and prioritized what we should be doing anyway. So my talk is to say why we should do it and how to do it, and if there are any new innovations that we might be able to do better with it. So, but before that, I'd like to tell you a bit more about Hong Kong, because this is where I'm from, and the priority is that we have a 7.5 or 4 million population in a very dense, small area. And we have the hospital authority, I was telling you, has 43 public hospitals in 7 clusters, 28,000 hospital beds, 1.8 million hospital admissions every year. And it takes up about 90% of all the hospital care for Hong Kong people. But we have a projected population of 1.9 million, 65 years old and above by 2026, and 2.7 million by 2046. So about a third of us are going to be retired and elders. So definitely this is a very important topic we need to talk about with infection control and MDROs. So this is the cluster of hospitals in color coding for Hong Kong, and the one in red is the cluster where I work. Okay, so I really don't have to say why we have to do MRSA decolonization. There are plenty of studies from Dutch groups and UK and Susan's to indicate that MRSA carriers have 3.9 times more likely to develop bacteremia. So decolonization is a good thing. 20 to 30% of the MRSA carriers are at risk of developing infection in the next 12 to 18 months. And there were plenty of studies going back decades to support this. And this is also the list of studies on how to do it, what to do it. At the time, there were no choice of PCR for screening or culture-based method and various forms in a smaller scale, which have been conducted over the last 20 years. But more important is also decolonization for Staph aureus carriage for specific circumstances like elective surgery and prosthetic device surgeries. So I think this was also shown in the last presentation by Susan, so I won't talk about it, but clearly large sample size RCTs, 6,700 patients, 2 arms, those randomized to be decolonized with mupirocin chlorhexidine regimen versus placebo, so reduction in the Staph aureus infection from 7.7% in the placebo group versus 3.4% relative risk of 4.42. So clearly large-scale RCTs to demonstrate the effectiveness. Nasal carriage of Staph aureus, also there's plenty of literature. So this is a systematic review of all the reduction in risk or as a risk factor for infection, being a Staph aureus carrier. And now, aside for elective surgeries or surgical patients, there are also patient groups that you see here that also are at high risk, firstly for SA carrier, as well as risk for infections. So these are maybe the targeted groups in your hospital that you should focus on as well, beside the other high risk with surgery and ICU. Okay, so basically, there are certain factors you need to consider when you implement these MRSA screening. I'm not going to compare and prioritize the different specifics that Susan covered already in much detail, but overall, these are certain aspects that you need to consider in your own hospital. Effectively is the cost effectiveness, and to design a system for your own place, identify where your risk groups are, the test you are going to use if you are doing screening, and whether you will focus on universal screening or targeted screening, and the site to screen. I think mostly now we just do nasal plus one other site, such as wound, if there's a wound in the patient. And the regimen you're going to use for decolonization, and of course the capacity for infection control, besides hand hygiene, and also the infrastructure with the isolation facilities, etc. So these are some of the strategies and guidelines from various countries. I think the one we always often refer to is from the IDSA. Now it's actually SHE, IDSA, and the EPIC together, which was updated in 2022. UK, they also updated one in 2021 from the Hospital Infection Society. I think ASMIT is referring to the SHE currently, but there was some documentation earlier. And for Hong Kong, we also have our own one, which is probably modified from all the international guidelines we have. Okay, so I won't touch on this. I just refer so that you can look at it if you haven't been going to this. But I think what Susan had been telling you probably already identified the list and the group, which is very, very specifically updated in the summary as well on the decolonization therapy and the groups that will benefit for decolonization. So this is the UK one. So in general, there are, in fact, for the decolonization regimen, there's no difference. But for the background, I mean, I think in the US one, there's a lot of discussion on the universal decolonization versus targeted decolonization. And there are also different guidelines, of course, also for community MRSA, which is sometimes conducted separately from the healthcare side, which I listed here. But these are just some of the examples. I'm sure individual countries and places have their own guidelines for this purpose. So I think my focus in this talk really is, are there any alternatives to chlorhexidine and mupirocin ointment for decolonization? So this table are the studies that Susan already told you about, so I'm not going to tell you, so I'll skip through that. So there are also some other trials about topical decolonization, but essentially, it's very difficult to explain each one of them, I guess, but these are really reasonably large studies that support the effectiveness of topical decolonization. Okay, so maybe I skip through that. And so alternatives to the standard therapy or standard treatment that have been studied include use of oral antibiotics or additional antibiotics and SSD, selective decontamination of the gut. But these are more historic, and the trend is not to use oral antibiotics if you can prevent or avoid using it. But agents such as rifampicin, cloxacillin combination, clindamycin have been used. Okay, so this is also one example of this is just a retrospective cohort, but instead of using chlorhexidine, or on top of using chlorhexidine, sequentially the hospital switched to other agents. Okay, so what was used was the mupirocin here, and then a third for 2 years had been switched to ortenadine, okay, and then to neomycin. So these are sort of like alternatives that were available, and they are antiseptic as well. Well, and to see if the effectiveness will be as good. But what you can see here is that, I think, let me see. So, oops, sorry. There is no difference with the use of mupirocin versus neomycin. However, the decolonization or of the Staph aureus was only 50% with the ortenadine. Okay, so this is an alternative that was used in the UK as being available, and it was felt it might be, it has inhibitory activity against gram-positive and gram-negative organisms. I felt it might be an alternative choice. But however, 50% of the positive carriers remain positive. However, in terms of the reduction in the infection rates, there was no difference in the 3 groups. So there is also a group 4 in the bottom, which is the ones that came in for surgery that became positive on the day of surgery. Okay, so that is sort of a false negative group at the beginning, and were not decolonized. So the idea was that decolonization was done 5 days before surgery and also continued for 5 days after. And ortenadine body wash was applied once per day to wet hair and body, and use of mupirocin or neomycin or tenidine. So, but at the end, the conclusion was that there was no difference in the infection rates, although the decolonization was not very successful with the tenidine group. Okay, so I think the tendency is that we want to sort of modulate and retain the sort of colonization resistance of our commensals when we decolonize. So maybe this is the way to go, whether so that we do not remove the whole commensals using an antiseptic or more broad spectrum agent. So there are alternatives. Unfortunately, also, I cannot go through many of them, but many of them are really in preclinical studies, options and ideas that potentially it should work or may work. So the list starts with like the antibiotics we're not going to touch on now. Other antiseptics, for example, polyhexanide, 0.1%. In a small study also showed eradication. So maybe that is also possibly an option other than chlorhexidine, for example. There are additional use of antiseptic oral rinse, bacteriocins. Now, antimicrobial peptides are really host immune responses, but it could be stimulated by certain commensal bacteria. So maybe this may be an option to modulate the presence or the inhibition of the pathogen through this route. And it may remain the colonization resistance of the commensals in our flora. Another interesting topic are use of probiotics and quorum sensing inhibitors. And of course, other agents like nanoparticle formulations and formulation using much lower dosing of mupirocin, for example, may also be one option that will give as effective equivalent, and bacteriophages. Okay, so I've referred you to this review paper by Otto. So examples of this, I think, was shown before already, with Bacillus subtilis that that produces an AGR inhibitory peptide in the gut that can reduce intestinal colonization of Staph aureus. And at the same time, it actually also reduced the density in the nose. And use of this probiotic, Bacillus subtilis, is already in phase 2 study that have been conducted. So this may be one possibility that you can refer to and follow through. The other options of other agents like bacteriocins for nose carriage, again, competition between bacteria using quorum sensing AIP sort of inhibitors, or they have cross-inhibiting activities, and bacteriocins producing organisms like from Staph hominis, Staph caprae, which may also have inhibitory activities against Staph aureus. Okay, so there are quite a number of these compounds also in animal studies, one of which I listed on the top is the colonization of mupirocin-resistant Staph aureus in a mouse model, but it is using a formulation compound, the PGS, which is an FDA-approved agent, combined with mupirocin sulfur complex in a much lower concentration. There are also other agents like Staph aureus-specific lysine that have been shown to be more effective than mupirocin in a mouse model, in a skin colonization model. There is use of lysostaphin cream that eradicated MRSA from the nose in cotton rats, and also staphylococcal phages that you heard about yesterday with infusions for treatment, but possibly also eradication of the organism from the nose. Okay, so I think in summary, we need to identify the risks and risk assess the groups that you need to target and decide on a strategy. You need capacity building for infection control for the infrastructure. You need to identify and cost-effective analyze the logistics and the decolonization program. And good surveillance systems is important for MRSA and MDRO control. Thank you.
As mentioned before, we'll do the questions at the end all together. We're now really going fast. And it would be nice to have my presentation in this place instead of Barbara's. There's and I should have mentioned while waiting for the presentation that this session was organized, co-organized by ISAC, the International Society for Antimicrobial Chemotherapy, which Jeff happens to be the president of, and I'm a past president. I will be talking about now cleaning approaches, which might be far off your bench show, I would say, but we'll talk about cleaning and modern technology to support it. Is it indispensable or overkill? And I have nothing to, as a disclaimer. Why is cleaning so important? For those who didn't know that yet, Cassandra Zaldago showed this nicely in this study, showing that the number of microorganisms in the environment correlated with the number with the percentage of patients having an infection. Stephanie Dancer in the UK did exactly the same. Total number of hygiene failures correlated with the number of ICU-acquired infections. So cleaning is important. Should you actually care in which kind of room you come and who was in the room before you? And as you already heard from Susan, there is no 100% cleaning, and this will show if your pre-occupant had C. diff, MRSA, or VRE, your chance of acquiring those microorganisms 2 times higher than in other patients. So you should care who was in your room before. And again, as showed before, even if you do your best while cleaning your room really well, and this is a study in 35 top clinical hospitals, you will see that even at the best, you not come over 80%, meaning 20% of the high-touch surfaces will be untouched and uncleaned. So we might need to look for something to add on. Just as an introduction, cleaning does lots of trouble, vacant responsibilities, people don't know who is cleaning what. The cleaners are undertrained, underpaid, and have the wrong PR. The quality check of those do it professionally are still visible quality check. They don't use the spots like Susan showed you. They don't use ATP. They just look at it, which is completely senseless. And then we think about the place of technology, and that's what this talk is about. And there are 2 different ways of cleaning, having terminal cleaning and cleaning while the patient is still in the room. Terminal is in between patients, and obviously important to make sure that there's no transmission from previous room occupants. And Bob Weinstein from Chicago, and this one will everyone quote, given the choice between improving technology or improving human behavior, technology is the better choice. And I do have to agree with him on that point. So what are the automated room decontamination machines that are there, or main principles, I should say? It's number 1, hydrogen peroxide vapor, and number 2, UV, either UVC or PIX UV. But these are the 2 main systems used for terminal, or as additive, I should say, for terminal decontamination. Just showing 2 studies, one for each. This one on UVC is a cluster randomized study over 2 years, 9 hospitals, more than 25,000 exposed patients, meaning that the previous room occupant had a known MDRO. And what they show, and you see that in the column with the MRSA, they used quaternary ammonium compounds as a standard cleaning, the blue column, and then they added UV, and you can see that there was a significant reduction for MRSA. By the way, if they did the same with bleach, it did not work, which is not really well explained in the paper why we wouldn't expect an added value by putting UV on top of bleach. So, but overall, there was a 10 to 30% lower chance of acquiring the microorganism of the previous room occupant by adding UVC to the standard cleaning. If you look into HPV, I picked this study from Trish's group to show you it's a 30-month prospective cohort intervention study on 6 high-risk units. 3 of them had HPV on top of the standard cleaning, and they did follow up for 12 months. And if you just look at the subset within that study where the previous room occupant was MDRO positive, you can see that 10% in the standard cleaning were left with an MDO versus 4.1% where HPV was used. So that's a 50 to 60% reduction in the MDRO. And if you look into the overview, this is from a paper from John Otter, and he's clearly in favor of HPV. I have to say that both have impact, and I wouldn't say that the amount of log reduction is the only reason why you would choose for a system, because if you would do that, you would go for HPV. My personal choice is UVC, and that has all to do with the practical aspect. If you want to use HPV, it has a 90-minute cycle, whereas a 15 to 60-minute cycles for UVC. And you need to get the room ready, meaning door and air vents have to be completely sealed. You have to look for leakages, and you have to measure the concentration. So in doing that, it takes so much more time. At least in my institution, we don't even have the time to do that add-on the standard cleaning that was there. So which one you prefer has a lot to do with how practical can you get it organized. And then we come to the holy grail of cleaning or disinfection, which unfortunately we're looking for as the people were looking for the holy grail itself. It should be something that is effective, safe, automated, is cleaning or disinfecting surface and air, is reasonably priced, and you can use while the patient is in place, coming back to the point of Susan, that obviously we cannot clean all the time. So what can we do for that? And then ultraviolet light is coming into place again, and not the normal UVC, but far UVC, which is about 222 nanometer light. So if you look into this far UVC, it has unfortunately some minimal penetration into skin and eyes, so it's totally not penetrating. Most studies were done in vitro and in animal models only. There are no long-term safety studies in clinical settings, and there is potential for ozone production, obviously, because you always get ozone when you use UV. So, having said that, they do have a nice reduction. In this study, they used the UVC for MRSA reduction in dental treatment rooms, and you can see in the blue bars that anything that was unshaded worked perfectly with a 3.5 log reduction. In the moment you have partial shades, like in the green bars, there's a reduction already, and the moment you have a lot of shadow, it's fully shadowed, obviously that is the problem of UV light systems. They don't work as well. And again, there is a time plays a role, so if you increase the time, you get a higher log reduction, which is fine, because these systems are supposed to be used not only for quick decolonization, like the UVC system you have seen for terminal cleaning, but to be used for multiple hours a day, and you actually have to do that. And maybe I should go back and say that while the shade is obviously the problem here, that will be overcome with modern robotic UVC systems that are AI kind of steered and that find their way around the room themselves, detect how much UV they delivered at the different places within the room. So I believe that UVC will be actually, out of those two, the future, the better system. You can go even further and try to use visible light as about 405 nanometers. And it's nice, if there's one system I know about, they try to to do commercially. These people obviously will tell you that any kind of UVC, including far UVC, is harmful, and only the visible light is good. They try to use the violet blue to white light at the beginning of the visible spectrum of light. So if you look into that, 405 nanometer light technologies, are a few studies showing you that it actually is active, namely the violet blue light, particularly 405, has significant antimicrobial properties. They are lower than UVC light, but this limitation is offset by the fact that you can continuously use it, it's safe to be used, and you can use it in occupied environments. There were studies showing even effect of 405 nanometers on MRSA. There are newer studies showing the same effect on SARS-CoV-2 and influenza virus with this kind of light sources. But thinking about it when preparing this talk, I thought we have quite a few in vitro studies. There's not a single clinical study. There's no clinical study on MRSA. Seeing the fact that the first observation and the use of 405 nanometer visible light was done about 20 years ago, I'm wondering why there is no clinical study and any further use. So I think we still have to wait for that. Are there other solutions? The other solutions would be by designing bugs out. One of those solutions could be this sharklet skin, like surface micropatterns to limit bacterial contamination. Obviously, now we're entering a thing where it's not antimicrobial, but what's just easier to clean and maybe less microorganism to collect. So if we look into nanotechnology and antimicrobial coatings, as already said, the first one is to create smooth surfacely, so smooth that nothing sticks. And I think that's a dream, but it certainly might reduce costs of cleaning and it might reduce bacterial load. And for small high-touch surfaces, I would love to see the opposite, namely creating microspikes that are presently used in studies for part of the joint implants. So part of the joint implants, at least there are studies from Maastricht showing it nicely. They will be used with nanotechnology, creating microspike, literally spiking bacteria and killing them that way. And it works really nice to prevent hip and knee infections. So why not use them on high-touch surfaces? To my knowledge, it's not been done so far, but it would be an option to use nanotechnology. And then there are antimicrobial coatings from copper and silver or from chemical compounds. And they either are manufactured in, which is a better way, or they are like retrofits, and especially the retrofits always have the problem that they are prone to a rub-off effect. So if you look into just using copper, this is from Cassandra Saldaco, a nice study showing that when you have certain high-touch surfaces with an intensive care unit and you produce them from copper instead from the standard plastic, then you can see that there's a significant reduction of healthcare-associated infections and also of MRSA infections. Again, I have not seen a lot of ICUs with copper, despite the fact that this study is nearly 10 years old by now, or over 10 years old. In my country, using copper probably wouldn't be possible because it's stolen everywhere. So even from the public transportation system, so I wouldn't advise my hospital to use copper at the present time, but it's nicely working. And the same thing holds true to silver would probably too, but it's even more expensive than copper. This is just an overview that you have this kind of metals you could use to supply in your environment. You can use chemicals, as I already mentioned before, or you can have physical alterations with nanotechnology. The last group of possibilities, obviously just reducing bacterial adherence, but not killing the microorganisms. And what would be the last thing to possibly go to? Probiotics, even in cleaners. And there are already the first probiotic cleaners on the market. If you look into that, in my opinion, the best study done so far is the one by the group from Pedro Gastmeier, done by Rasmus Leisner in Berlin, looking into the cleaning protocol, comparing just detergent versus disinfectant versus probiotic. If you look into, and that is unfortunate in that study, The overall hospital-acquired infections, it was the same in all three groups. If I looked at the gram-negatives, overall multi-drug-resistant infections, so mainly gram-negatives, also the same, and they could only see an effect with regard to MRSA. So, and the effect was the same as with a disinfectant, you could say, and thereby they kind of concluded from this then, while there was no overall effect on MDROs, the trends seen with MRSA, in their opinion, probiotic cleaner might be a good alternative in this situation to the disinfectant, as it's non-toxic and a sustainable alternative. So probiotics might be a chance. There is, we did recently an overview of all the probiotic studies, which will actually come in the ERIC journal next month, I believe. It was just accepted. And we showed that there are mainly, and all this is based on mainly Italian studies, and in the Italian studies there was a significant effect of overall HIIs and reduction of antimicrobial resistant genes. Again, I would be kind of cautious, as this is mainly based on several studies from one group in Italy. There's one little predicament for the use of probiotics. There's this wonderful RCT showing that terminal room disinfections in ICUs has a significant protective effect against transmission of MDROs. So if you try to work with your probiotics, obviously every single time the patient leaves and is well cleaned with detergents, with disinfectants, your new microbiota from the room might be gone. So we don't know what to do in that case. So in conclusion, for terminal disinfection, HPV, UV are both there. They are add-on technologies which I would use for certain high-risk patients and in high-risk environments. Which one you prefer has to do with the time and the investment and money you would like to do. I believe that UV will be the future, certainly when the robotic and the AI is making these methods even better. Most cleaning methods with continuous effect, or those I hoped for, like probiotic activated quad or other things, have limited activity until now. They also have the problem of being rubbed off. If you want to apply them, you need long wetting times. It needs to be wet for at least 2 minutes to apply this activated quaternary compounds before they even work, and you have to do that multiple times because anytime you rub over it, it's gone. So I think there's limited value. The use of far UVC is less effective, a little bit less effective, and we need to see real clinical data showing that there is no harm to the patient. But that was the better thing. Nanotechnology as microspikes, which I mentioned, or visible light at 4 and at 5 nanometer, it might be something for the future, but there's absolutely no clinical evidence whatsoever, and it's something I would love to see. So coming back to the question I had, modern disinfection technology to prevent MRSA, is it indispensable, like a lock on a bike in Amsterdam, or is it an overkill, which some people do too, to ensure that their bike is still there when they return? I'll see them as I see my own bike in Groningen. This is a really nice electric bike, and it looks really impressive. It's super smart. It doesn't even drive without your phone. It's trackable. It has just a kick lock. You don't have to lock it anywhere because it's useless for anyone to try to steal it. You can't use it. But the problem is it's completely not trouble-free. You could say it's very troublesome. It has a lot of practical issues, but it gives me hope, and it helps enormously. And if you have the money to do it, you should have a bike like that or the technology. Thank you very much. With that, we are back exactly to the time where we had to be, but I would like the two other presenters to come up again just to see if there's 1 or 2 questions we can answer, because we have that. And I already see the first question. Would you come up, please? Sorry. Steve.
Hi, thanks. Steve Tong from Melbourne. I'm interested, the focus here was on MRSA, but I wonder if the conversation actually should be about more broadly preventing staphylococcal infections. Why are we so focused on MRSA? And in fact, preventing hospital-acquired infections. So I think it's too narrow a focus. And certainly, you know, the universal decolonisation approach is not just focused on MRSA. My second question, and I think, you know, the Netherlands has led the way here, is the other intervention of selective decontamination of the digestive tract, and where does that fit into this this story about hospital-acquired infections?
Actually, it was only after the talk from Michael on the first day and the mentioning of the studies before again that I thought about it. STD is in all our intensive care units. There's none that's not doing it, as are the decolonization of MRSA patients, as are the preoperative Staph aureus decolonization. And maybe the fact that we have so much STD is one of the reasons why we are so low in multi-drug resistant organisms and Staph aureus. It's a really good question. Our ICU patients don't have gram-negatives. And I see like 1 or 2 patients with MRSA bacteremia a year for one of the largest university hospitals. So 2 would be a lot.
No, I mean, the data are very compelling, but the preference to not use to preserve systemic antibiotics for treatment is high. So we don't use it in the United States.
Well, yes, I think in the older days, in the literature, there's a lot about STD and your experience is that it works. But I think now you really have to look back at your reservoir and your background bacteria, because they were using colistin and various drugs. And I think it depends on the susceptibilities as well. From 20 years ago to that of now, the choice of the drugs may be different. So I can't say it doesn't seem to be used so much now, but it was used literally 20 years ago in specific patient groups, yeah, and ICUs.
Okay.
Regarding the MDR, I totally agree, because in Hong Kong, probably in most of Asia, gram-negatives are really the thing we really have to target, and that really helps, I guess, with the, yeah.
I could add to it that unfortunately decolonization systems for patients harboring gram-negatives are less well established than those for staph. That is one of the main problems. If there is no other questions, I thank you very much for spending the lunch with us. I'm thanking the organizers that ISSSI was allowed to co-host this session. And I think that some people are desperately waiting to get the poster prizes or to give them away. So we will be stopping right now. Thanks a lot. And thanks a lot for all the speakers.
Hello, dear colleagues. I am Dr. Ünal from Hacettepe University, Ankara, Turkey. I am the chair of the Turkish Society of Hospital Infection and Control. And this year, we are very lucky and honored to host the 33rd International Congress of Chemotherapy 2024 in Istanbul, together with the International Society of Antimicrobial Chemotherapy. Our program committee has prepared a very strong one, including the subjects from antimicrobial susceptibility testings, wars and infectious diseases, artificial intelligence and infectious diseases, bacteriophage therapy, infection control, and many more. And beyond that, Istanbul is a lovely city, as you know, connecting Europe to Asia, full of history. I'm sure it will be a very successful, strong congress and pleasurable time in Istanbul. As one of the co-chairs, I invite you to join us in this beautiful activity. See you all in Istanbul.